Alright guys, so today I'm going to be talking about extubation in the ED. We don't really do it all that often, most of the time we're just intubating and just sending them up to ICU, but today I'm going to be talking about extubation in the ED just because I had a case just the other day at Moses. So the case is as follows. I get him on sign out. Gentleman's 40 years old, history of high viral load, history of esophageal strictures, coming in for a food impaction. He's had it before. He says that he ate some boneless chicken last night and felt like it got stuck in his chest. Ultimately, he gets scanned. He's protecting his secretions and he's not, vomiting his brains out. The thing's right there in his mid-esophagus, about 2 centimeters by 2 centimeters. GI gets called. They say, he's doing okay. Watch him, give him the glucagon, see what happens. And so, hours go along. I get him on sign out at 7 a.m. It's 12 hours out. So I call them again in the morning. What are we doing? It's not passing. The guy still feels terrible. So, he needs to get scoped. A couple hours go by, and finally they go, fine, we'll scope him, but only if he gets intubated in the ER. He will not up in the endoscopy suite, down in the ER. Which kind of leads me to the question, if we're intubating him in the ER, that kind of also commits us to the extubation, which made me wonder, is this something that we should be doing, just in general? Both intubation and extubation, it's a big resource. It takes a lot of resources. Nurses, residents, attendings, respiratory. There are probably better places for this to be done, whether it's in the PACU or even the ICU. So the answer to this is probably yes and no. There's only really been 2 studies that have examined extubation in the ED, one in the US by Weingart and one in the UK. Both of them were in the setting of trauma patients and whether there were any sort of complications with these extubations, whether they got re-intubated. And both of them, albeit small studies, showed that it's probably okay. So why does this matter? Well, if the issue's resolving, like with the food impaction, it can sort of avoid a necessary ICU admission. It reduces the length of stay. If you pull the tube out, if he doesn't really need it, you can avoid all these complications of prolonged mechanical ventilation, whether it's barotrauma, O2 toxicity, pneumonia, or even really any sort of fatigue, muscle fatigue. That being said, if you do pull the tube, you should just also keep in mind that up to 12 to 15% do require re-intubation, and the second go-around may even be harder than the first. And up to even 30% could get laryngospasms or some sort of upper airway edema. So, who are the patients that we should consider in taking the tube out in the ED? I would say that it's probably those that get intubated only really for the short term. The intox head trauma patient with normal imaging with improving mental status. The one that probably got intubated in the field and significantly improved. There's also the OD patient that may have also gotten intubated in the field and dramatically improved by the morning. Then there's also obviously the case like the one I had the other day, the elective cases where the person just needs to get scoped. Once the scope's done, you can take the thing out. And there's also the small subgroup of patients who are palliative, who no one really knew the code status, so they got intubated in the field, and you find out that they didn't want any sort of aggressive care. So you can probably pull those out as well. And so now that we have our subset of patients that we kind of know can be extubated, how do we know they're ready to be extubated? So the criteria is pretty much the same. The same criteria you use for intubation, you use for extubation. Can they maintain a patent airway? Can they oxygenate and ventilate? And is their anticipated clinical course a good one? So for the first one, the airway. Are they able to follow commands? Can they do so over the long term rather than just for like a couple seconds? Number 2, was it an easy intubation? It's kind of a bad look if they're the heavy-set sort of person with a fat neck and you're taking the tube out just to slash the neck to crack them. So you want to make sure that the ones that you're really doing, make sure that you'll be successful. Number 3 and number 4, cuff leak and the cough. So what a cuff leak is basically a test to see if there's any sort of laryngeal edema. What you do is you deflate the balloon and you kind of just look at the vent. You compare the inspired tidal volume versus the expired tidal volume. If there's any sort of discrepancy, that's a good thing. That means that there's air that's going to be able to leak around the tube out of the patient. So really, according to Weingart at the very least, if there's a 25% change amongst the two, that's a good thing. While you're doing this, you can also unhook the ventilator itself, occlude the ET tube, and have them cough. If you can hear an audible cough, and this is more a qualitative sort of evaluation, that's also a good thing. If you don't have either, there's actually upwards of a 10 times chance that once you extubate them, they're going to have a post-extubation stridor. So it's just something to keep in mind if you do decide to do this sort of thing. Next, can they oxygenate and ventilate? So are they pretty much able to breathe like you and me comfortably on minimal vent settings? To test this, you put them on pressure support. After having taken off all the sedation and having them be adequately pain controlled, you put them pressure support at a pressure support of 5. You have to leave it there for a little bit, between 15 to 30 minutes, just to see how they do. If they're able to tolerate it, then good, you're done. And so some of the things you want to look for is, are they mentating well throughout the entire course? Are they making good tidal volumes throughout the entire course? And as far as Weingart's protocol, he kind of pegs that at 5 cc's per kg. Are they having normal vitals throughout this entire thing? Saturating well, not tachycardic, just pretty much comfortable while you leave them on the pressure support for the ensuing 30 minutes. And lastly, the anticipated course. Will they be hemodynamically stable post-extubation? Basically, you're looking at pretty much the comorbidities. After being on the vent only really for a couple hours, will they tolerate coming off of it right away? Do they have that strong cough? Do they have these laryngeal edema? Like, will they be able to come off of it and stay off of it? So, in preparation for all this, these are just some of the tips that you can do to see if to sort of help expedite the process. So if it's something elective, like an endoscopy, you can use a smaller ET tube so that it doesn't really irritate the cords as you're putting the tube in and as you're pulling the tube out. Use quick-acting medications, something like propofol, quick on, quick off, so you're not standing there for the next 2 hours waiting for the stuff to wear off. And be very liberal with the pain medications. Whether it's the intox patient or the overdose or even the endoscopy patient, if they're comfortable having the tube in, then their respiratory status will be good as well. And I think it should really go without saying the fact that you should have the airway cart nearby. You never know what's going to happen. They could very easily crash. The chances of reintubation, as I mentioned before, is anywhere between 12 to 15%, so you never know, and there could be a chance that you're going to have to reintubate them. And so right before you're going to do the procedure, you have to suction them very thoroughly. Do the oral pharynx with a Yankauer, through the ET tube, so that you can get all the secretions out, so that you can give the guy the best chance that he can to get the tube pulled out and maintain that. Finally, you just pull. You sit them up, you have them cough a few times, and basically ask them to take a deep breath, and as they exhale, tell them to cough, and just in one fell swoop, just yank the thing out. That's kind of all there is to it. But, with post-extubation care, you have to watch them for a little bit, whether it's laryngospasms or laryngeal edema. It's that really first hour, that's kind of the golden hour where, something can happen. If something can happen, it inevitably will. On top of that, you want to put them on oxygen, whether it's just simple nasal cannula, nebulized saline, or even albuterol, just to kind of open them up. Having proper oxygenation will give you the best chance of preventing reintubation. And even if it may come down to it, if they get put into respiratory distress, you could even try BiPAP, though all the oxygenation stuff should theoretically work just as good. So what happened with my guy? So with our guy, he got intubated, he got the piece of chicken pulled out. Kind of took a little long, especially because we paralyzed him for him to come off of everything. Could have probably used a little bit more analgesic, which I didn't do. But we pulled the thing out, and he did pretty good. He needed some nebs. We gave him the suction to just suction himself, and he kind of just discharged himself once he felt better. So, I will say that extubation in the ER can be a feasible thing. You just have to kind of keep in mind the pulse of the ER to see if you have the available resources, as well as really your comfort level and what kind of case the patient is to pull the tube out. Anyways, so take-home points. ED extubation is probably only meant for those that are intubated in the short term. The long-term ones should probably be done in the PACU or the ICU. The criteria to use for extubation is exactly the same as it is for intubation: pain, airway, clinical course, as well as oxygenation and ventilation. And the last thing is just you got to prepare, because you never know what will happen, and just know that in the back of your head, ultimately they may need to be re-intubated if it comes down to it. So that's kind of it. These are the references I used, and questions?